John Daugirdas. I'm chairing this session, which is a very exciting session. It's called the Lifelong Legacy of Childhood Kidney Disease. And the purpose of the session, we have two great presentations one from Dr. Julie Ingelfinger, who's professor of pediatrics at Harvard Medical School. And she's a senior consultant in pediatric nephrology at Mass General. She's had a lot of particular interest in intrarenal renin angiotensin aldosterone system. And then we have a second set of presentations by Dr. Maria Ferris, who's professor of pediatrics and adolescent medicine at the University of North Carolina, Chapel Hill. She's professor and epidemiologist at the University of North Carolina, and she's been very active in looking at the issue of transition of care for pediatric dialysis patients and patients with pediatric patients with CKD to adulthood, and has developed some very interesting tools. She'll be also assisted by Ana Catalina Alvarez Elias, who's a fellow who trained at the National Autonomous University of Mexico, and her main interests are outcomes in solid organ transplant and pediatric renal replacement therapies. I had asked each of the presenters, I sort of did a little précis of their slides, and I thought that it might be useful. I don't know if this will work, but to run through 4 or 5 key slides from each presentation, and then I thought the speakers could ask their polling questions, which they submitted ahead of time, and then we can have time for questions from the audience, if that's all right. I don't know if Julie, Maria, Anna, I see you're here, so.
Okay, so I'll just go through these. Go to the next.
Go ahead.
Next. I just wanted to remind everybody about the legacy of developmental origins of health and disease as it portends to kidney disease. And this is really based on work from the 1980s and really before, from the Barker hypothesis, which suggests that perinatal perturbations lead to altered organ development in the case of what we're interested in, the kidney, and low birth weight or reduced nephron endowment are surrogates, or low birth weight is a surrogate probably for reduced nephron endowment. And Brenner felt that the fewer nephrons, the more hyperfiltration, and that portends future hypertension and kidney disease. If you can go to the next slide, I will say that what we now know is that in this plastic perinatal period, there's a lot of possibility that fetal exposure to nephrotoxins or to poor blood flow in utero can lead to epigenetic changes that, in fact, can lead to differentiation slowing, to things in the developmental niche as the kidney develops changing, and so fewer nephrons forming. Next slide. So we see this epidemiologically, and fairly recently, Calderon-Margel et al. Showed in Israeli army recruits, where they had everybody so they could look at what happened to them, what their past history was before being in the army growing up. And what's shown here is that any kind of unresolved condition with kidney injury led to a much higher incidence of end-stage kidney disease. And that was true whether it was some developmental congenital abnormality or somebody who'd had acute glomerulonephritis or HUS. If it didn't totally resolve, there was much more chance that it would progress. Next slide. So what can you do about that? I think most of us are aware of this, and an important thing at this point is to do simple things. Record gestational age and birth weight, monitor people who are former preemies or were small for gestational age, obviously document at-risk events or kidney injuries, even mild, avoid nephrotoxins, and educate the family, the patient, and the healthcare team that these are people who need follow-up. Next. So that in general, if one looks at things, if you look at the contribution of congenital kidney disease or inherited disorders and acquired kidney diseases, there is a contribution of nephron number, the yellow you see on this slide, that increases over life, and that the contribution of these changes is very important. And so the steps we can take are at this point pragmatic, but the data from epigenetics and from pathways that are involved is becoming a rich data source. And I would predict over the next decade, we will know more about what we can do to intervene. So that's it for my slides at this point.
Anna Catalina, do you want to go through your slide presentation?
Okay, so thank you, everyone. Just like Dr. Daugirdas said, I'm Ana Catalina, and I'm still a fellow. I like to study. So basically, what I wanted to make an awareness to everyone is how the chronic or end-stage kidney disease that starts during childhood has an impact in adult life, because at the end, we send these patients to the adult care. So there are so many things biologically and psychologically speaking that the adult folks need to be aware to know how to better improve their outcomes and prognosis. So you can go to the next slide, Dr. Daugirdas, thanks. So basically what I wanted to show in this slide, first of all, is that there are not too many registries about chronic and end-stage kidney disease around the globe. And unfortunately, it is mainly because there are not enough resources that are invested on creating these kind of registries. But as you can see in this slide, which there is showing incidence and prevalence from the URSD registry that was done in 2003, you can see how United States is showing a high incidence, being the first country in the left panel and being the third country for prevalence in the right panel. So you can see there how there are some countries that are kind of first world countries that are showing high incidence and prevalence. However, we cannot rely on all these data because probably some of the undeveloped countries, they don't even have a registry to show how prevalent and incident is in our population, CKD and end-stage kidney disease. The next one, yeah.
So yeah, I looked at the slide, and it was very interesting to me was Japan, because Japan should have a good registry. And why do they have such a low incidence of pediatric kidney disease as opposed to the US?
So there is a very interesting, there is a very interesting data from Japan, because they are one of the countries that have reported the highest incidence in IgA nephropathy. They are screening the kids very early on life. So they are doing urinary tests. So they are catching the cases early on time. So they are doing awareness, screening, and prevention more than other countries. So yes, you're right. Japan is a developed country, but they have a lower incidence. Probably this is one of the reasons. And the other one, we cannot deny that there is a genetic factor to develop kidney disease. For instance, we have APOL1 that has been investigated about this. So ethnicity also matters in these cases, Dr. Daugirdas. So here we can see how the etiology of chronic and end-stage kidney disease in children are widely different than in adults. So we can expect the complications that they have or the burden that they have is related to this. So we can see how infants have congenital abnormalities of kidney and urinary tract, while the adolescents have a great incidence in glomerulopathies. So these acute patients that we call are exposed to multiple surgeries and a lot of issues in the urinary tract that can burden in the adulthood, while the patients that get it as an adolescent, they are exposed to immunosuppression and complications to that immunosuppression and acute events that they can have. And here, as you can see, it's shocking how the cause of death keeps being cardiovascular disease for our patients as well. So surprisingly, we can think that children are not too proclive to have this complication, but they yet are having this because at the end, they are having a cardiorenal syndrome type 4, which all the complications from chronic kidney disease that the adults can develop, the kids are developing as well. Fluid overload, FGF23, and all of those kind of things are making them develop cardiovascular disease. And even if they don't present it very frequently during childhood, they will present it early in the adult life. Next one. And in this part as well, it is very overwhelming for them because they have to perform at school. They are trying to have a normal life, but we can see how they are not developing the same that a normal kid. They have impact in all the systems and in a very vulnerable time of their life where they are developing. So in this cartoon, you can see how the controls have more activation on their brain than the patients that they have chronic and end-stage kidney disease. And it's also proved when they are having like hemodialysis treatment, how they are not well perfused as a normal person. So they have a burden on that. Thanks.
Good. Okay, Maria, so you're up for the last 4 slides.
No problem.
Please, excellent.
I want to just, because we have a number of adult-focused providers in our audience, I just want to tell you the point of this slide, which is, while we know that only 2% of our graduates are in your population, and while they're supposed to be less adherent to treatment, know less about their diagnosis and disease, and are considered the healthiest, they really are still developing. And the issue of them coming with parents should be leveraged, because patients who have somebody helping them with their health, like a spouse or a parent, they have better outcomes. Next slide, please. So we have created a program of transition. We measure healthcare transition readiness. We have these tools. We also, in this website, you will find tools to help them learn about their disease. These tools have been used for both pediatric and young adults in the pediatric and adult focused setting. So you're welcome to use those. Next slide. I think that one important slide has to do with what is in the way of learning about their disease or healthcare transition readiness. And a lot of the social determinants of health, along with a non-cohesive family, are barriers for healthcare transition readiness. Next slide. And one point I want to tell you is that while you adult providers mind that the children come, or young adults come with their parents, they actually, the young adults and adolescents, prefer their parent as a source of information over the provider and anything else. They don't like to go to the internet, because they really go to the internet, from what they tell us, they go to the internet to have fun and not to learn about a disease that they don't want to have in the first place. So this was an eye-opener for us, and we've continued now to focus on teaching the parents how to teach their young adults and adolescents about managing their disease and about their disease. Next slide. So when we do healthcare transition readiness or self-management, we use 4th grade level material. We speak in plain language. We have adapted our educational modules to be based on cognitive and behavioral characteristics of the patient. And again, adult nephrology colleagues, please take advantage of the parents, even if they're involved, but help them delegate health management duties. And last thing I want to mention is that the brain of the, and I don't need a slide for that, the brain of the adolescents and young adults really does not become an adult brain until they're in their mid-20s, about 25. All the connections take place, and that's when they're in your realm. So you need to help us help these young adults become good citizens and good managers of their health.
So I wanted to look at the chat. I see no open questions. So Hannah, can you or somebody run through the polling questions? We have. Great. So Julie, you can, if these are your questions, you can go ahead and ask them, and we can see what the audience answers. Can you read it? Can you read it?
Okay. So what is the most important flag for the risk of future chronic kidney disease to put in your patient's medical record? Is it birth weight? Is it the GFR, estimated GFR at age 2 to 4? Is it maternal blood pressure during pregnancy? Is it nephrotoxin exposure during the newborn period?
But go ahead, Julie, if you want to just go through the questions.
Well, so the second question is, how should you manage an infant or a young child at risk for CKD? And it's perform a urinalysis and check kidney function every 1 to 3 years, focus on family education and lifestyle optimization, avoid nephrotoxins or all of the above. And the third one is, if a child has an episode of acute kidney injury at age 3, but recovers fully, no proteinuria, normal blood pressure, no decrease in estimated GFR or calculated GFR, what is his or her risk for future CKD? Minimal or no risk? There's still some risk even in the absence of proteinuria. Minimal or no risk provided nephrotoxins are avoided. No risk if kidney protective medications are instituted in childhood. So for time, okay, so now we can see those. So I will comment if that's okay. And that is, I think the most important flag is really what is the birth rate weight, which is obviously a surrogate measure, but both people who have worked on the Barker hypothesis or developmental origins will say birth weight, and those who are interested in hyperfiltration will also say birth weight. And for the second, how should a young child be managed? And that is all of the above, which most of you agreed with. And third question is, yes, indeed, as 70% of you said, there's still some risk, even if things look perfect. And that is something that has become obvious only in the last 10 or 15 years. People who are old, such as myself, were taught as fellows that if somebody got over acute kidney injury, they were going to be fine and live to 110. We now know this is not true. So bottom line, look at possibilities for who's at risk and follow them vigilantly. And this doesn't have to be by a nephrologist, but we need to educate generalists that this is incredibly important, and we need to document these things in the record. So that's all I have to say at this point.
So maybe we can do the other polling questions from the other two speakers.
So one of the questions that we asked was, why is it important to continue healthcare transition or self-management preparation in adult-focused services? And the options are pediatricians don't have enough time, adolescents do not really believe they can take care of their health, young adults with chronic conditions learn to self-manage their health until their mid-20s, or none of the above. Ana Catalina, you want to read the second one?
Sure. Why is healthcare transition preparation? It is an issue of patient safety. We must follow the first to do no harm. Pediatricians often do not prepare the young adults prior to transfer to adult-focused services to avoid having to deal with parents, none of the above.
And I don't know if you guys can see the third question, but the third question reads about what are helicopter parents, and they're too involved in their childcare and do not delegate health management duties. They're okay with their child managing their own health. Helicopter parents are impossible to deal with, or none of the above. And then can you see the question number 4, Ana Catalina?
Yep. Among adolescents with chronic conditions, what is the most preferred source of information about their disease? Their health providers, peers with the same condition, their caregivers, internet, none of the above. What is the most prevalent etiology of CKD and stage kidney disease in infants? Nephrotic syndrome, hypertension, congenital abnormalities of the kidney and urinary tract, genetic disorders. And the last one, from whom do adolescents and young adults would like to learn about their disease? Peers, healthcare providers, social media, parents.
I think we wanted to emphasize that question. So,
Okay, so maybe you can go comment on the answers of what the audience thought.
So, well, it's interesting. So why is it important to continue healthcare transition? And I think most of the group got it. So young adults like to learn, can learn about their disease or learn self-management until their mid-20s. We actually have data demonstrated that in our transition program, we go across to the adult focused services and we enroll patients up to 29 years of age. So we have evidence that not only by their brain developing in their mid-20s, but they really do learn to self-manage their health and onto their mid-20s. Now, question number 2, way to go, audience. Yes, it is a patient of safety because there is great morbidity and mortality. Once the patients leave the pediatric focus setting, it is not very clear as to why, but they do lose their organs or they have more rejection for those of them who have transplant. But this is not an issue of just CKD. Patients with other chronic conditions have the same safety issues. Patients with lupus, patients with arthritis, patients with diabetes have a higher hemoglobin A1C. Also, we've learned this from other countries. They have similar experiences. I only see two. Oh, there you go. So helicopter parents, everybody knows this. I think most of us have some helicopter parenting altogether, but imagine you having a child with a chronic illness. And I think that if you look at the literature, helicopter parents, children of helicopter parents do actually much better in terms of survival and in treatment adherence, but they don't learn to manage their health by themselves. So that's a double-edged sword. Then question number 4. Well, interesting. It's a tie between peers with the same condition and their caregivers. We have published that actually the number 4th characteristic or number 4th source of information is actually peers with the same condition. And at least in CKD, part of the problem is that they're so isolated because their condition is so rare. So it's hard for them to network with peers of the same condition, except for in the clinical settings. In the internet, everybody understood that question. Ana Catalina, you want to address number 5 and 6?
Sure. What is the most prevalent etiology of CKD and stage kidney disease in infants? And yeah, most of you got it. It's congenital abnormalities of the kidney and urinary tract, as we mentioned. That's over 40% of the etiology in that age range is due to these congenital abnormalities, and kids go through a lot of surgeries and a lot of burden in learning how to deal with their bladder, with recurrent infections, and also with other issues like malnourishment, get fed by tubes, and so on. However, saying all this, we have seen that kids that have such an early start are the ones that adapt the best to their disease because they grew up with that. It's the way they know to live. So they are usually very knowledgeable of how they deal with their disease, and also they accept very well all the course of their disease, comparing with adolescents that they can have onset during adolescence. They are not used to have this condition, and it's really shocking for them. So most of you got that one. And then number 6, again, from who do adolescents and young adults would like to learn about their disease? And in this one, looks like you got it as well. Parents is the most important one. You addressed that peers. Sometimes it's challenging as well for the patients to talk about their disease with others that don't have the same condition. Sometimes they are embarrassed to be different. They want to fit in the group, so they don't even comment about that. So it's unless they really trust in another peer that has not a chronic condition, they usually try to hide it from the group just to go through adolescence and be able to fit. So it's mostly from parents, and I'm glad nobody chose social media.
Very good. So thank you all. I don't know how much time we have left because we started late, but now I think it's 10 minutes after. I only see one question in the chat. If anybody has a burning question, I think it would be good if they put it into the chat. The one question so far has been to all the panelists. Do you support comprehensive genetic screening in children with kidney disease? From an attendee. And obviously that depends upon the situation, but who wants to take that? Either Julie or Ana Catalina or Maria?
I'm always willing to open my mouth, and that is, I think that increasingly we're learning that having genetic screening can turn things up that would be very helpful. We're at the start of an era in which personalized care based on specific genetic variants may be very important. And while it might not even lead to anything at first, I think if it's available, I would now advocate for it strongly, a position that is somewhat new for me. If you'd asked me this 5 years ago, I would have said, well, maybe not. But I think that new treatments that are really tailored to a very small number of children that make a huge difference can be turned up from this. The downside is if something is found and there are laws based on prior existing conditions, even if they haven't printed out yet, that can be a problem. But I think there are safeguards being put in place for that. So when possible, I'm pro. Now, Maria or Anna, you can answer. And John, you can too.
I totally agree with you, Dr. Julie. I think that evidence research is supporting more and more to use genetics to help us to find out how they respond to treatment, prognosis, even recurrence of diseases after transplantation. So I think it's quite important if we have the resources and we have how to do a comprehensive screening of the patients when they are available, and also to develop infrastructure in our institutions to go to these, because sometimes, just like Dr. Julie said, are rare diseases that we cannot test as easy. But what I have seen, at least in the Hospital for Sick Children, we team with other hospitals and we do it sending samples and so on to get the kids to have a diagnosis. So I agree, in this era where we are towards individualization of therapies and personalizing medicine, I think it's the best approach when available, and to develop the resources to have them more and more for the children.
I'm going to agree with both of you. And again, I want to reemphasize what Julie said. 5 years ago, I would have had a different answer. The problem still in our country, at least in the US, is who will pay for this. And I hope that at some point we'll be able to overpass this issue. I would like to say a sentence on in terms of closing remarks. I do so much appreciate your attention and interest that you're taking on the care of adolescents and young adults with CKD or end-stage kidney disease, while they are only 2 to 3% of your population. They are patients who have great survival. At 10 years, adolescent onset end-stage kidney disease at 10 years has a greater than 85% survival, either on dialysis or transplant. So these are patients that are coming to see you while there's not enough of them compared to your diabetes and hypertensions. patients in your clinic. They are patients who are a lot of fun to take care of, and you can still help them grow up. You can still help them become young adults who are productive and can manage their disease. So thank you for letting us have this opportunity to discuss this important topic.
Okay, well, I think that there are a couple of more questions, but I'm afraid we're just out of time. I think this is also the end of the day to talk, and I'd like to thank very much Julie and Maria and Ana Catalina. It was a wonderful presentation, and thank you so much for a great discussion.
Thank you.
And we thank you for your game moderation and your knowledge and participation in this field. I, for one, admire what you do.
Thanks.
Thank you so
I
much.
actually don't know why they asked me to chair this session, but it's very informative for me. I love learning more in areas where I'm not expert. Thank you so much, Julie.
As we wrap up day 1 of the 23rd RI International Conference on Dialysis and Advances in Kidney Disease, my wish is that you benefit from the creative and valuable online networking opportunities. The poster sessions and industry symposiums and networking lounge build and foster relationships and create collaborations that would not otherwise be accessible offline. These sessions provide the opportunity to develop online interactions with industry thought leaders, medical professionals, researchers, and scholars. They also provide a place to discuss exchanges and developments on the latest scientific advances and best practices in kidney care and treatments. As a reminder, if you haven't had an opportunity, please view the speakers' prerequisite sessions in the on-demand library. This will enable you to maximize your experience and participation in the live Q&A sessions tomorrow. We also encourage you to explore the virtual poster sessions and engage with industry leaders and partners and benefit from all the valuable material and information. We thank you for joining us today and see you tomorrow.